we'll see about the post-transplant case discussion regarding the history and examination format. As I told in the glomerular disease case also, like we can divide the history and examination into 5 parts. Here also it is part A and part B is basically the history, C and D is examination, and part A is the urine examination. In the post-transplant case, the most important part is the part B. In this video, we will see only about the part B. Part A, as I told there, it is the basic disease where basic details of the patient have to be there. Part B is the most crucial step because in a post-transplant case, the examiner can have a clear idea from the way you are presenting the case itself, whether you are having a knowledge about the post-transplant cases or not. From the history only, he can easily find it out. So we will see the approach, how we are going to make the part B. At the end of the part B, what are the things should be clear? We should know about what is the basic disease which led to the CKD, what are the complications of it, CKD, whether the patient is having or not, RRT, why it is started, what are the complications of RRT, why the patient opted for this transplant. These are all the basic details the patient should have. From the part B, like the initial part, we should focus on this history, and then the subsequent part with respect to the post-transplant case, we should have a clear idea about what was the risk factor in the pre-transplant period, donor details, what was the matching technique which was utilized, important details with respect to transplant day, immediate post-transplant period, first week of post-transplant, discharge and post-transplant complication. This is a very extensive history in the post-transplant case, and here also we will get only 45 minutes. If it in the final exam, if it is the first case, maximum you will get 45 to 50 minutes to complete everything along with the examination. So that's why, like this history, you have to be thorough with what are the things to be asked. And this arrow regarding the progression of these things over a period of time. Here also we are going to approach the history based on the previous detail only, that is history of presenting implied past, personal, family, these basic details only. If the CKD onset is before 20 years, the birth history have to come in the history of presenting complaints only. This birth history we will see in the case history of CKD in detail, what are the things to ask and all. So this skeleton remains the same. First we will go to the history of presenting complaints. Many a time in the basic details only, you can start as patient is a case of post-transplant, done on so and so date, came for chief complaints of fever or rise in creatinine, like that you can mention. Or if the patient came for follow-up, you can mention patient underwent renal transplant around 1 year back, whatever it is, and now came for follow-up. Like this you can start your history. From the history, then going to the history of presenting illness, you have to say as, I want to start the history back from the beginning of the symptoms, approximately 3 years back, 4 years back, wherever it is, from the time the patient was apparently normal. You have to start as patient was apparently normal in 2010. Then we started noticing, like what are the symptoms, maybe you have to start from there. There also you can club it, similar to your glomerular disease, tell about renal symptoms, cardiac symptoms, renal symptoms in the form of GN, CKD, RSD. Just you have to formulate accordingly as per the patient symptoms and the important negative history then and there. So whatever the important negative history, you can say according to the patient symptoms, like focus on the cardiovascular symptoms, lung symptoms and the GI symptoms. Rest of the things remains the same. Focus on the CNS symptoms, autoimmune. Here any negative history, don't need to tell like extensively as far as the glomerular disease, but whenever there is a suspicion you want to rule out the basic disease, like focus on the important negative history. Chronic interstitial nephritis, because at the end of these parts you should have a clear idea about what is the basic disease of the patient. So these two history forms little bit important during the progression of the patient complaints. Regarding the drugs, Ayurvedic medication, related to infection, malignancy, related to hypertension, whether it is primary or secondary, how was the controls, diabetes about, how diagnosed, about macrovascular complication, microvascular complication, what was the progression. This how you have to mention as per the patient present complaints. You can delete few of these points if the patient doesn't grossly not matching into any of the category. So at the end of that 11 points, from starting from kidney till the end of 11 points, you should have a clear idea about what is the patient's basic disease, whether it is chronic glomerulonephritis or CTIN or ADPKD, whatever it is, you have to be very clear, because the questions start appearing from here only. Because in the post-transplant period, there is a chance of recurrence, depends on the patient's basic disease. So you should know about what is the percentage of recurrence which can occur in any glomerular disease. It is given in a PERITONEAL as a tabular format. You should be aware of that. CTEIN, whatever may be the etiology which led to the CKD, it is having very much significance, because it might recur in the post-transplant period if that factor is not being corrected. And if the basic disease is known, whether it is the usual rate of progression is there or not. For example, if the patient is having IgA nephropathy or podocytopathy, you should know what is the usual rate of progression. Sometimes IgA nephropathy patient might present between the symptom onset and the CKD, it might be less than 2 years. Then they might ask, is it the rapid progression common in IgA nephropathy or not? You should have an explanation for that. It might be a crescentic transformation, or there might be superadded hypertension, or there might be superadded chronic tubulointerstitial nephritis. If it is ADPKD, what is the usual onset? What is the usual rate of progression? If it is a diabetes, the usual rate of progression after macroalbuminuria is around 10 ml per minute per year, like that. You have to be aware about what is the usual rate of progression. So how to mention about that? That is the sequence of the history of the patient developed symptom when he was declared to have CKD, and how it was declared, whether ultrasound was done or not. That point also you have to remember. Then subsequently, after those details are obtained from the patient, then you have to ask regarding the CKD complication. The symptoms of this complication and the etiological symptom might overlap. So you have to frame the history like accordingly. If you have mentioned about anemia in the prior part, no need to mention it again. If you mention about seizures before, no need to mention it again. Just you have to be clear that whatever the things you are going to ask for with respect to the complication. With respect to the complication, we have to ask about the anemia, weakness, blood loss, increased menstrual bleeding, blood transfusion, whether he is on EPO regularly or not, when he used to take EPO. Regarding CKD MPD, because these are all the major complication in the case of CKD. With respect to CKD MPD, you have to tell about the bone pain, any history of fracture, any investigation done or not. Like if the patient is an educated person, he can tell about the degree of PTH also, regarding cirrhosis, skin ulcerations, dry skin. These are the very common complaints. Cirrhosis and the itching, which this leads to itching. Chronic itching is an important factor or important complication associated with CKD, which is also a factor deciding the quality of the life of the patient. With respect to the CNS, seizures, vision loss, any symptoms of hypotension leading to visual blurring, those kind of complication you can think and add it in this. And what is the general thing regarding the quality of life? How is his sleep? How is his sexual functions? These are all the general things which are related to the CKD, and whichever important complication, you have to mention over here in the sequence. Then subsequently, why RRT was started, whether it was emergency one, elective one, how was the drug compliance? Because after the diagnosis of the CKD, patient might be started on drugs like renoprotective drugs or other important drugs. He might be started. What was the reason the patient went into RRT requiring state? If RRT was started, how it started, whether it got emergency or elective. Why it is important in a post-transplant case? It is important because it having a impact on the post-renal transplant course. If it is elective, the prognosis is somewhat better, and if the drug compliance is good, probably the patient will be having good compliance in the post-transplant period also. If the compliance is poor in the pre-transplant period, there is high chance of immune suppression, non-compliance. So in the subsequent period, there is, like if there is a graft function, you can add it as an important point favoring rejection. And what was the vascular access, whether as per whether this was fistula or whether it is catheter. If it is catheter, is there any complication during insertion, and what was the residual urine output at that time? Residual urine output is important predictor of mortality, so that have to be mentioned as in the due course. Majority of the patient symptoms might have started 10 years back, and at a particular time you have to mention, and it is very important at the time of starting dialysis what was his urine output, and whether vaccination he took, viral markers, whether it was done or not. Vaccination, you have to tell about hepatitis B vaccination. Majority of the time patient can mention. If the patient is not remembering, it is important you have to mention, sir, I have asked for this, but patient could not remember regarding the vaccination status. And if the patient is able to tell, well and good, you have to tell about influenza and pneumococcal vaccination also. If he was started on dialysis with a catheter, you have to mention why it got failed, why it was removed in short. In CKD, MHD case, it have to be in very detail. Since in the post-transplant case, time is limited, you have to mention important. If it is a CRBSI, history of recurrent CRBSI, there's a poor quality of life and associated poor sometimes graft outcome. So these are the things you have to mention. And if the AV fistula failed, why it failed? That is very important. Whether the patient developed hypotension or recurrent failure, because patients are having coagulopathy. Why this history is very important? Because if the patient have coagulopathy, there is a high chance patient might develop in the post-transplant renal vein thrombosis, renal arterial thrombosis. There is a high chance. Then you have to think of working up for coagulopathy related disorders. So that's why this history is important. And the AV fistula multiple failure might be seen in diabetes. That is also important factor, because post-transplant you have to think of sugar control. There is a chance of post-transplant diabetes that might lead to graft dysfunction. So these are all the things you have to ask with respect to the RRT at the time of starting. And what are the drugs he is on, and what was the BP control at the time of starting dialysis, and what was his compliance and the diet, whether he was taking high salt diet or not, because high salt diet associated with the higher blood pressure, more ultrafiltrate removal, more complication. Whether he is taking low salt diet or high salt diet, this have to be mentioned to tell the examiner that you are knowing these are all the parameters which might be having an impact on the mortality. Weight gain and the average. Suppose if the patient is on thrice weekly hemodialysis or twice weekly hemodialysis, the average weight gain and what was the residual urine output at that time have to be mentioned, and any intradialytic hypertension. Any blood transfusion patient received, EPO, post-transplant, what are the injection he used to receive, that you can mention in short. Coming to the transplant, we have to mention why he opted for transplant. Since if the patient is on RRT, he might have some problem with RRT, or his quality of life was poor, or overall, theoretically, transplant is having the best outcome for a transplant for a CKD patient. After the counseling, whether he opted or for any particular reason, that you have to highlight over here. Coming to the pre-transplant risk factor. So you should know what are the risk factors for rejection. In general, what are the risk factors? Blood transfusion increases the antibody production, pregnancy, any vaccination, any previous surgery, any prior transplant. These are all the important theoretical risk factor which will impact the post-transplant rejection rates and the high HLA mismatch. So as the history continues, you have to mention about blood transfusion. Now we are going to tell about the history of transplant. How we are going to tell, like start with the blood transfusion only, because examiner will have a clear idea. You are knowing this in the background of your mind. Like in total, how many transfusion he have received. For example, 4 unit packed cell he have received so far. What is the blood group of the patient? If the patient is female, any pregnancy, vaccination he received or not, whether he is remembering or not, you have to just highlight to show the examiner that you thought in these lines. Coming to the donor, you have to tell what is the age of the donor, example 45 year, 50 year, what is the EGFR done by EGFR of the donor at the time of donation. Majority of the educated patient will tell about the EGFR. If the patient is totally illiterate, and you can mention, I have asked for this EGFR, the patient would not remember. Blood group, ABO compatible or incompatible, comorbidity does he have? For example, if the patient is having diabetes without end organ dysfunction, then patient is fit to donate. If he is obesity, he might have reduced weight to donate. There might be some other comorbidity, might or might not be associated. So you have to tell us the patient 45-year-old female who was a mother with eGFR of 90 was the donor, ABO compatible without any comorbidity, and he or she underwent cardiovascular examination and found to be fit. Then they have decided to donate. And other important history with respect to this, why other family members didn't agree to donate. Why this point is very important? Because the matching chances is better with the parents, father to son, mother to son or daughter. The matching HLA match is better. Sometimes the wife will be donating. Then what is the reason? Why father didn't donate? Why mother didn't donate? Why brother didn't donate? That have to be compulsorily there, because the chances of blood relation donating kidney compared to a non-blood relation donating kidney, that is spouse, the outcome is better with the blood group related donors and the siblings. So we have to show the examiner you are aware of these factors also, whether the grandfathers are alive, these kind of things you have to mention. If the family members or no, if the spouse donates, if the family member didn't donate, or if the sibling donate and the mother father didn't donate, you have to mention the reason. So this step is an important component at this time. So pre-transplant history we have completed, donor history we have completed. Then coming to the matching history, we have to tell about what are the things he have, what are the investigation he have underwent. Majority of the patient might have tell you the name, whether he underwent CDC, flow, HLA when it was done, or you can mention the patient underwent investigation. If he is not able to tell, then you can tell about the patient underwent investigation which is worth about 30,000 rupees, which was being done by, and he is not aware of the reports. What was the matching degree, whether the patient was told about whether how much matching was there, good matching or poor matching. Whatever the history patient will able to tell you, you have to convey at this point of time. If it is a ABO incompatible transplant, you have to tell about the plasmapheresis, whether it was done or not, what are the drugs started, what are the whether immunoabsorption given or not, anti-A or anti-B titer have to be mentioned. And if it is there, when it was started. Suppose if it is the transplant day, if it is a immediate post-renal transplant case, majority of the patient, even illiterate patient, might be remembering around -10 days back they might have given rituximab, titer might have been done. 4 days back they might be given tacrolimus MMF, and the tacrolimus level might have been tested over there also. Why we have to mention over here? Because TAC is one of the important cause of tactosis in the immediate post-transplant renal dysfunction. So you are catching the etiology of the renal dysfunction at this point only. So this point is very important. The HLA match, high degree of HLA mismatch is an important risk factor for graft dysfunction, early onset rejection. Low TAC level is an important risk factor for rejection. High TAC is an important risk factor for CNI toxicity, acute tubular necrosis, thrombotic microangiopathy. So you are catching the etiology of renal post-transplant graft dysfunction at this point. So focus over this history. You have to tell about TAC dose, rituximab dose if the patient remembers. On the transplant day, it is very important to know about the induction, whether the patient was given any induction or not. If the patient remembers, to tell bezaliximab or ATG. Why ATG or bezaliximab is important? Because there is high degree of infection rate if the patient received ATG, and a low chance of rejection, low chance of ABMR if the patient received a high degree of induction. If the patient didn't receive any induction, there is less chance of infection in the post-transplant period, but there is a more chance of rejection. So these are all the important points which are hiding behind these histories. Sometimes patient might have told he was supposed to buy a drug worth rupees 70,000, 80,000, that is pointing towards ATG. So you can ask by the cost wise also, how much he have told he have to spend. If the patient able to tell about warm ischemia, time cold, you can tell the examiner that you have asked for these things, but the patient could not remember. How long the surgery lasted, what was the blood loss if he was informed about, what was the immediate post-transplant period urine output, whether any hypotension he was informed about, because you are picking the differential diagnosis. Points favoring, points against will come from the history only in a post-transplant case. So next, coming to the immediate post-transplant period, majority of the patient will be having renal dysfunction. Like in the final exam, the case you are getting 99.9% will be having any chronic graft dysfunction or acute graft function or any infection. So so further history should be framed to pick up the differential diagnosis. What are the differential diagnosis in gross? Rejection, drugs, especially high CNI or low CNI. Infection, CMV, PKV, any infection. In the first month, that is the Rubin's table. First month, 3rd to 6th month, after 1 year. Bacterial, viral, and this subsequently depends on the immunosuppressive state of the patient. Obstruction, it can be any obstruction. Renal artery, renal vein, or ureter obstruction, which might lead to UTI. Recurrence, usually recurrence is occurring over years only, but FSGS is the one condition which can recur immediate post-transplant, which might require plugs. So these are all the ideas you should have, and the history, the way you are presenting only, the examiner will come to know whether you had idea of this condition or not. So coming to the important part, which is the immediate post-transplant period, you have to tell about whether the patient is on steroids, how much milligram the patient remember, tacrolimus, MMF, or cyclosporine. If it is so, what is the dose? When was the tacrolimus level done, and how long after how many days it is being repeated? You have to tell about the steroid toxicity, especially how was his sugar, how was his blood pressure, because CNI is one of the things which can cause high blood pressure. So if it is high blood pressure, how many drugs he was taking, and what was the drug modification which was done after getting the tacrolimus level. What was the urine output? Urine output you have to tell in sequence, because in the immediate transplant there will be very high output in the range of 10 to 20 liter, or depends on the patient, it might vary, but usually it is in the range of 10 liter and above. And you should know what are the reasons for very high urine output immediate post-transplant period, how it is progressed. Suppose if a patient is having 3 liter urine output in the post-transplant period, that is not adequate, because in the immediate post-transplant period the urine output have to be high. What are the causes? A very high uremic state. So that's why in the pre-transplant period, if you mention about creatinine, that will also be better. And the denervated kidney, these are like the theoretical part of this point we will discuss separately, because video will get more and more lengthy. This urine output part, very important. You have to tell over a period of days how it progressed, and what was the creatinine trend. Creatinine they used to repeat daily. They will ask for the creatinine, when we have to do creatinine in the first month, how to follow up every day till first week we have to do, then subsequently 3 days once, then weekly once, then monthly once. There is a protocol. You can go through the FIGALI or the handbook of nephrology. Any HD was received, any biopsy he underwent, and any feature of diarrhea or infection. Why diarrhea? Because it is one of the complication of drug MMF, whether he developed any pneumonia, if he received ATG. So your history should cover all these points, because each and every point is having a significance with the graft outcome. Then first week, by the end of the 5th day, you have to tell about the creatinine, and you have to bring the diagnosis. Here one important diagnosis lies with that you have to tell at the summary only, which is slow graft function, delayed graft function, or immediate graft function. There are varied definitions for this. They will ask what is the definition of this. There are definitions based on creatinine. There are definitions of based on urine output. The simple definition I will tell you here. For slow graft function, if the creatinine doesn't reach baseline by day 7, that is low graft function without the need for HD. Or you can tell another definition, if the creatinine doesn't come below 2.5 by day 5 without need for HD. Delayed graft function is within the first week of transplant if the patient received any hemodialysis, that is delayed graft function. Other definition you can go through this. Immediate graft function is if the patient creatinine level reached baseline within 7 days, or if the creatinine is less than 2.5 within 5 days. That is immediate graft function. So this definition you have to be clear from the history only, because this diagnosis you have to tell at the end of the summary. What are the drugs he is on? What are the modifications that have been done? Whether the blood test for CMV was done or not, any other specific investigation like PSA was done or not, whether the patient underwent any plasma, if it's a ABO incompatible, whether the titer was done. If you know the details, you have to tell. Otherwise, you have to tell you have asked for this, patient is not able to tell. Because CMV prophylaxis is of two types: preemptive treatment and prophylactic treatment. Prophylactic means you put the patient on drugs irrespective, and for 3 months you have to continue. In prophylaxis, you have to preemptive, you have to check the CMV titer, then you will decide upon. Each is having its own advantage and disadvantage. What are the patients who receive prophylactic treatment compulsorily have to receive ABO incompatible transplant, high induction? It is better to give prophylactic CMV prophylaxis with valganciclovir. Valganciclovir cost around 900, approximately 900 rupees per day. Even it costs around, depends on the brand, 1000-2000 rupees also. So the patient pill burden will be high. If the patient remember the drug, you can tell. Otherwise, you can tell patient was on many drugs and the pill burden was high, how much he used to spend on the drugs. That will give you the clue about valganciclovir. So indirectly, you are telling the examiner you thought of CMV, and you know that CMV is an important risk factor for graft dysfunction if the patient is ABO incompatible or patient received any induction that you have mentioned in the prayer. So sequentially you are mentioning. And any feature of side effect in the form of diarrhea, headache, high BP, vision blurring. These are all the very important things. And other important things at the end of the first week is that you have to tell when these tubes were removed. When the artery removed, central venous pressure catheter removed, drain removed, Foley's removed. If the patient is having any perinephric collection, the drain might be retained. So usually it will be removed within 5 days. If it is removed after the 5th day, there is a high chance the patient having any perirenal collection. Perirenal collection might be lead to UTI, or you can suspect any obstruction. These are all the factors you will get. Foley's, when is removed, because UTI is common if the Foley's is in situ. Degestant, when it have to be removed. Ideally, it have to be removed on the 14th day. Urological people are having two protocol: early and late removal. Early means 7th to 10th day. Late is after the 2nd week. Why it is important? Because if it is retained in situ, there is high chance of rejection. If it is removed earlier, there is high chance of ureter leak. What are the causes of ureter leak? It is one of the important factors. UTI, ureter necrosis. The questions will be framed here only. If the history is clear, they might not ask, they might directly go into the theory part. So don't miss any of this history. And at the time of discharge, you have to tell about the urine output. What was the creatinine at that level at that time? Because we are going to make a diagnosis of chronic graft dysfunction or slow, immediate, whatever it is, based on these things only. And the time duration passed. What are the drugs patient was on? How was his BP control? How was his sugar control? Because the patient is on high dose steroid, you have to tell about the tapering. If it is on high dose steroids, one important risk factor is diabetes. So you have to mention that. When we will tell us post-transplant diabetes, it is after 45 days. If the sugars are persistently high, we have to label as post-transplant diabetes. So that is why this sugar control is very, very important. Then post-transplant complications. Suppose a patient present on the first year post-transplant. After mentioning the history till discharge, then you have to say as post-transplant days. For example, the final case, in the final exam, the case I got was post-transplant. The patient had endophthalmitis, diarrhea, UTI, pneumonia. So you have to mention as post-operative day 40, the patient developed features of diarrhea. Diarrhea you have to elaborate in detail. Similar to a simple diarrhea, what was the content, how like whether blood was there or not, loose, watery type, abdominal pain, diarrhea, how it got improved, what investigation was done, what was the CMV level, what was the drug modification done, everything you have to tell in detail. Then post-operative day 50, what if the patient develop pneumonia, whatever the event the patient develop, you have to tell us post-operative day. If the patient is after a long period of post-transplant, if he presents, you have to tell about in months also. 3 months he developed the rejection, biopsy was done, after the drugs was modified. On the post-transplant month 8, he developed like UTI, features of UTI, fever, whatever it is, you have to tell in that sequence in the post-transplant period complications as. Then subsequently the history comes, which are same as past history, personal diet, just focus on the diet, how is his compliance. And one more important point is, throughout the time you have to tell about the drug complaints. In India, the most common cause of graft dysfunction, like practically at least basis, sometimes many of the illiterate patient will be non-compliance to the drugs. That is very, very important. So don't miss that history over a period of time. So the progression is very, very important over here. Personal, family, drug history. Drug history, you can no need to tell it separately if you mentioned in detail in the like preceding part. So after this step, so yes, this long case is very, very extensive. Taking this all the history within a span of 45 minutes, which include examination, is very, very, very difficult. Unless you practice, if it is a first case in the final exam, it will be very difficult. So practice this case presentation at least twice or thrice before your final exam. So after the end of this summary, like history of presenting illness, we are knowing the basic disease which led to CKD, what are the complications the patient had, why the RRT was started, what are the problems he faced, what was the residual urine output, because these are things which is associated with mortality. Why transplant he opted, and basic disease why important, because chance of recurrence 100% question will be there. Once you finish the summary, the viva probably start from there only. So you have to be very clear at that basic disease. And in the pre-transplant, we have told the examiner, we are aware of the pre-transplant risk factor. We know what are the factors of donor which will affect the graft outcome. If the eGFR is good, outcome is good. If it is the older donor, outcome is good. Like, we are informing the examiner. We are informing about how was the matching, if it is ABO incompatible, how it got tackled. On the transplant day, what was the induction given or not, because we know induction is associated with subsequent outcome factors: high induction, low infection, high rejection. Low induction, high chance of infection, low induction, less chance of infection, high chance of rejection. And the immediate cold ischemia time, warm ischemia time. Regarding this cold ischemia time and warm ischemia time, there is a separate video, like you can go through that. They might ask the definition of this, why it is important. This is also associated with the graft outcome. Immediate post-transplant period, about the drugs, CMP, rejection, ATN, whatever the important history we have asked. What is the discharge creatinine, so that we can form the diagnosis of slow, delayed or immediate graft dysfunction, and what are the post-transplant complication. So from the history only, we are showing the exam, we are clear about all these things. Suppose if the history till the end, if it is very clear, most of the time you are already reached the passing zone, because in the long case the history is the most difficult part to complete, and telling it in a clear way is also very important. No need to repeat the things, because these are the things which might super add. There are few factors which might super add between these things. So you match accordingly as per the patient timeline. So only one point I want to mention over here is whether you will tell chronic glomerulonephritis or chronic tubulointerstitial nephritis after history. How to tell? Because in chronic glomerulonephritis, the edema is yearly. Presence of oliguria, prothuria, anuria, hematuria, rapid progression is common in glomerular disease. Hypertension is yearly onset in glomerular disease. Anemia is there, but is yearly and severe in chronic tubular interstitial nephritis, but anemia can be there. Any autoimmune feature can be associated. Urine might be showing active sediments. Patient might be on any immunosuppression pre-transplant period. So from the history, these are all the points which favoring towards the chronic glomerulonephritis. If the patient underwent any biopsy, well and good. But majority of the CKD we get in the long case, the patient might not have underwent biopsy because at the diagnosis only his kidneys might be shrunken. So they will ask what are the points favoring chronic glomerulonephritis. There should not be any doubt in the basic disease, because if there is a doubt or confusion in the basic disease, the viva might not proceed further. So if they ask, just tell these 6 points whether patient is having this or not. Because of these points, I am probably suspecting it is CGN. If there is a family history of ADPKD, or the patients are told about the presence of cyst, then you can tell about the basic disease is ADPKD. What about CTIN? Usually the edema is of late onset, once the kidney loses majority of its function. The oliguria, proturia, anuria, hematuria might not be there. Like in NSAID induced, it might be there. Majority of the time, it might not be there. Hypertension is of late onset, but it will be of severe degree. Why? Because the patient will be in volume overload state because of the renal mass loss. So it is of late onset, but it is of severe. Anemia might be early because of the peritubular interstitial fibroblast, which secrete EPO, because it is chronic tubulointerstitial nephritis. The fibroblast get lost. So anemia is of early onset. These are all the points favoring. Patient might be on any chronic NSAID, painkiller intake, or Ayurvedic medication intake. He might not be on any immunosuppression. Recurrent UTI might be there. Birth history if you take, then you can fit it accordingly. If it is any reflux disease, so based on the history you have to formulate, and these are all the points favoring CGN or CTIN. If any, I don't think I have missed any point. If any point is missed, you can add it up. So at the end of the part A, basic details, and the part B, you have to tell the diagnosis. The diagnosis have to be told in this format. It's a case of live related renal allograft transplant. What about the wife? Wife is a related or not? Wife is a emotionally related. So even if it is spousal donor, you can tell us a live related renal allograft recipient on which day is important. And for example, January 2022. The basic disease leading to CKD, probably chronic glomerulonephritis, with a dialysis vintage of 2 years, with the donor being mother, age 32, whatever it is, like 60, whatever it is. Induction, patient received ATG, with the immediate graft function, with the hypertension, with the anemia, with the post-transplant complication of diarrhea, CMV retinitis, and the UTI. For example, in my final exam case, I got this like complication over a period of months. So how I have mentioned, so I am telling you the example, like you have to tell us it is a case of live related renal allograft recipient of January 2022. See, the basic disease which led to CKD is query CGN, possibility of CGN, and the dialysis vintage is 2 years, ABO incompatible transplant, wife being the donor, blood group B to A positive, with the ABO titer, whether the patient underwent desensitization or not. If he underwent in a ABO incompatible, the patient underwent desensitization in the form of rituximab and 2 plex. Induction being besileximab, immediate graft function with the hypertension, with the anemia. Anemia, why we are telling? Based on the history. If the history is not suggestive, don't tell, because you didn't examine the patient so far. Pallor will be found on examination. With the post-transplant complication, post-operative day 20, diarrhea, POD 40, UTI, POD 50, like rejection, ABMR, with the chronic graft dysfunction, whatever it is. So this forms the complete diagnosis. So around 6 points have to be there. Transplant state, basic disease, dialysis vintage, donor, if it is APO incompatible, desensitization, induction. Either of these 3, after the 5th day you have to label immediate, slow, delayed, comorbidity, post-transplant complication. If it is within the first week, you can tell only the one, but usually in long cases it might be 1 or 2 year post transplant. There will be a serial of any complication. So every month you have to elaborate the detailed history, whatever the patient developed. Yes, this history is very extensive. Practice the history, and there won't be time to complete the history even these kind of long cases unless you know the subject in depth. So that's why this is very important. But once your history is complete, like till this point, even before the examination, in the long cases you are already like into the safer zone. If the examiner come to know your the protocol of asking the history is clear and you are knowing the subject, what to ask for in the case of transplant, you are thinking in lines of risk factor, rejection, everything you have asked, most probably the Viva will switch over to the theory part. And in the next video, we will see about the what are the important examination finding we should not miss in a transplant case. Examination we will see in the next video. Bye.